Hello, good morning, everybody. Welcome to our first web show in 2013, and Happy New Year to all of you, by the way. We are here with Dr. Swingle today to discuss one of the most popular topics nowadays. Are you sure it's ADHD? We can all be a little inattentive, impulsive, or even hyperactive, so how can a specialist tell if the problem is ADHD? Before I get Dr. Swingle to talk about that, I'd like to introduce Dr. Swingle to those who are with us for the first time. Dr. Swingle was titular full professor of psychology at the University of Ottawa prior to moving to Vancouver. Fellow of the Canadian Psych Association, Dr. Swingle was lecturer in psychiatry at Harvard Medical School, attending psychologist at McLean's Hospital in Boston, where he also was coordinator of the Clinical Psychophysiology Service. Dr. Swingle is registered psychologist in British Columbia, certified in biofeedback and neurotherapy. His newest book, Biofeedback for the Brain, was published by Rutgers University Press, and you can get the book at www.soundhealthproducts.com. Again, that is soundhealthproducts.com. Okay, if you have a question to ask, you can type it in the chat box located on the control on your right. If you look at the control panel right now, there is Chat tab which you can click on, and that opens the chat box. Type your question in and click Send. That's all. I'll be collecting your questions, and we'll have 2 breaks today to answer them. Well, we are all ready to get going, so let me welcome Dr. Paul Swingle. Good morning.
Good morning. Well, this is one of my favorite topics, ADHD, because I think this is one of those conditions that points out how silly some of our diagnostic and treatment procedures are. This and depression, I think, are the 2 examples of the silliness of doing top-down versus bottom-up diagnostic processes. Okay, so with that unbiased opinion, let me get started here. Okay, the diagnostic criteria for ADHD, and this is the inattentive type. So you see you have 9 characteristics there. Fails to give close attention to details, so forth, difficulty sustaining attention. The question I always ask is, what if you have 5? Do you not have ADHD inattentive type? And this just gives silliness new meaning. On the other hand, if you are the hyperactive child, you need 6 or more of the following 9. And again, what if you have 3? So again, the whole process of top-down, in my judgment, is just not efficient. The most critical thing is, so you put a name on it, now what? It doesn't tell you where to go or what to do to try to deal with these behaviors that are problematic. And we have a similar scale for adults. How often you have problems remembering appointments or obligations and so forth. How often do you feel restless or fidgety? And again, there's a criteria here. You need so many items checked for it to be classified as attention deficit disorder. Now, having said that, children who have difficulty sustaining attention in the school situation, those who have an attention deficit problem, are really prone to problems in adulthood. Individuals who have this kind of experience as children typically have a lot of difficulty in school, have trouble keeping up. Their self-esteem takes a huge blow, and there are certain forms of ADD that are particularly pernicious. There's a form that is associated with effort, in which the brain often looks fine at rest, but when you challenge it, that's when you see the problems associated with a certain waveform that blocks the child's ability to sustain focus, but more importantly, to retain information. And the characteristic of this pernicious form of ADHD is that the harder the child tries, the worse the situation gets. So these are the kids that just quit, have become problematic in school, and they're the ones that are represented in these figures that I'm showing you on this slide. Adults with an attention, who have had a history of an attention problem, show comorbid mood and anxiety disorders. Alcoholism and drug addiction is huge. In terms of criminal behavior, if you look at the number of individuals who are in prison and the frequency or the number who have characteristics that would fall into the ADHD category is extraordinarily high. So you can see here, these are data that I think came, if I remember correctly, came from Australia. And the percent of greater than the general population, 95% greater than the general population to be arrested, convicted, and so forth. So it's a very, very serious issue. Not only has it caused trouble for the kids, but it has a long, long legacy in terms of failure and erosion of self-esteem and inability to sustain work, to maintain meaningful relationships, and so forth. Lots of causes of inattention, and the focus of this particular webinar is to look at not only what we might call bona fide conditions of ADHD, but other conditions that cause inattention. And this is particularly problematic because very often the child is medicated for an inattention problem. The problem has nothing at all to do with that. It may be a function of head injury, depression, anxiety. Bullying is absolutely huge problem for these kids, and if they're frightened or humiliated, they have a lot of difficulty sustaining attention and intention. And of course, we have family problems, sleep problems, and physical problems. I always like to show a work of art before we begin any presentation, and this is a work of art. And what this is a properly functioning brain. Now, and on the bottom here, what you're looking at is the spectral display, and the very slow frequencies are on the bottom, a half a cycle a second, and the faster frequencies are up on the right side of the spectral display. That's up around 40 cycles a second, up in the gamma range. And you can see it's nicely distributed there. The algorithm is that intensity or amplitude is inversely related to frequency. So the slow frequencies are stronger than the faster frequencies. And in the upper part of the screen, you're seeing, first of all, the white line on top is the raw signal. And then the raw signal is broken down into the components, and that's done with either fast Fourier analysis or filtering. So on the top we have the theta, and theta are slow rhythmic waves, as you can see there, between 3 and 7 cycles a second. The next one is alpha, extremely important waveform. And that's about 8 to 12 cycles a second. And beta, the faster frequencies, are on the bottom, 16 to 25 cycles a second. And this is actually a feedback screen in which theta is represented by this bar here that's moving up and down. Alpha is the second one and beta is the third. So we can instruct somebody, if we're trying to do neurofeedback, to say, let's keep the blue line below that green line, so that we're trying to decrease the strength of theta. And you can see that it's above training threshold now, and the person might be not getting a tone. It's getting a tone when it's below that that threshold line. So this gives you an idea of what a nice functioning brain would look like. Nice, orderly, rhythmic waveforms, and nice algorithm. This is what a common form of attention deficit disorder looks like. This comes from the data from Dr. Siegfried Othmer. And you can just see this by inspection. This is the theta right here, the low frequency, and you can see the difference between a child without an attention problem or hyperactivity problem and a child with a hyperactivity problem. The amplitude of that slow frequency is considerably greater in the hyperactive child, and the corollary of that often is the strength of the high frequencies is less in the hyperactive child than it is in the child without a hyperactive problem. Now, what that means, translation, is that the brain is hypoactive. When you have a lot of slow frequency amplitude, the brain is hypoactive, it's underactive. And this is a condition in which medication stimulants would be effective, because what the stimulant does, obviously, is it stimulates the brain. And this is a brain that's understimulated because of excess slow frequency amplitude. And the hyperactivity of the child is actually self-medicating behavior. The child needs to bounce around to get some stimulation up into the cortical regions in the brain. And it's actually painful for the child to sit still. So it just gives us an entirely different conception of how we look at the condition of hyperactivity in the child. It has nothing at all to do with volitionally being problematic and so forth and so on. The child is in discomfort, and the bouncing around reduces that discomfort. Now, we have several ways to address this. We can address it with central nervous system stimulants, methylphenidate, for example, or we can address it by using neurotherapy to normalize the brainwave activity of this hyperactive child. Now, it's interesting that the American Pediatric Association just raised neurotherapy to position 1 that is most support as an effective treatment for hyperactivity among all of the other treatment modalities. This is what it would look like if you're looking at a topograph. Now, a topograph is simply giving you color representation of the strength of a waveform. And the red, orange, and yellows mean that the area is strong, and the light colors, the blue and the greens and so forth, means that it's weaker. So this is showing marked elevation of slow frequency, all over the brain. So there's your topographical representation of what we were just looking at, which is the issue associated with elevated slow frequency for children that have ADHD. This is an adult, and this is the form of ADD that I mentioned earlier, in which everything looks honky-dory at rest. It's only when you challenge the brain that you get this increase in slow frequency, which causes the problem. So you can see here the ratio of the amplitude of the slow frequencies, the ones we were just looking at, to the faster frequencies. So the theta-beta ratio is sitting at about 2.1 when the brain is at rest. We want it below 2.2 or so, and you can see it jumps substantially when we ask this person to count. So this is that form of ADD that can be particularly problematic, and that is the brain's going the wrong way. When you're making an effort to concentrate, the brain is producing more slow frequency, thus increasing the problems associated with retention retrieval of information. This is another form of what we call actual ADD. And this is referred to as the high frontal alpha form. This is a 12-year-old female. And this is F4 is the right side of the front part of the brain. F3 is the left side of the front part of the brain. And remember now that the amplitude of a waveform should be inversely related to its frequency. So theta should be highest, alpha should be next highest, and beta should be lowest. And you can see there's a big bump at the alpha. So alpha is much stronger than it should be, and that's a form of ADD, and it's associated with problems with planning, organizing, sequencing, following through on things, and staying on target. It also tends to be associated with highly social kind of chattiness and bouncing around kind of behavior. So this tends to go undiagnosed in females, or at least it did in my day. So the culprit there is elevated alpha activity up in the frontal region in the brain. So these are the legitimate forms of ADD. What I mean by legitimate is these are the factors, the neurological factors that actually influence the child's ability to sustain attention, the child's ability to maintain quietude, and the child's ability to plan, organize, sequence, and follow through on things. And it's a neurologically based condition. And where we're seeing that is for the high frontal alpha, it's sitting up in the front part of the brain here. The elevated slow frequency that's associated with hyperactivity, you tend to see that right over the sensory motor cortex in the center of the brain. And those are the conditions that we usually identify as what we will, for lack of a better phrase, call bona fide ADD. The way we treat it, very straightforward. We put the wire on the head where we want to measure the activity, set it up so that when the brain's doing what we want it to do, icons move on the screen. When the brain stops doing what we want it to do, it stops. And we have all kinds of games and situations that we can use to keep the child's interest so that the more they focus, the more the icons move on the screen. So it's a very straightforward procedure. This is straightforward neurofeedback treatment of choice according to the American Pediatric Association for non-drug treatment of the attention problems. Now, at the Swingle Clinic, we have an alternative method of neurotherapy referred to as brain driving. Now, neurofeedback, the one that I just showed you, is based on what's called instrumental conditioning. That is, when things are going the way we want it, you get a reward. So that reward can be a tone or it can be something moving on the screen. Brain driving uses what we call classical conditioning. And many of you will remember Pavlov and his dog. And when you put meat powder on the dog's tongue, the dog will salivate. And if you ring a bell simultaneously with putting that meat powder on the dog's tongue, after a few trials, you ring the bell, the dog will salivate without the meat powder. Okay, straightforward classical conditioning. I've done a lot of work in terms of classical conditioning of waveforms, and one of these webinars we'll be talking about trauma, and trauma is a classical conditioning event in the brain. But this refers to how we treat the brain using classical conditioning. Now, we're set up here so we can present light stimulation at the eyes, we can present sound stimulation, and we can present electrical stimulation of acupuncture points. There are many other things we can do, but this is a standard protocol that we use. For children, we don't use electrical or electromagnetic stimulation. We only use light and sound. The glasses that we use are dealing with attention and learning conditions in children look like this. That is, they're open lens, and the lights are situated around the perimeter of that open lens. So they can be looking right through the goggle while the lights are being turned on and off. So they can be doing reading or mathematics or whatever. They can be tasking, in other words. So we asked the child to write while we were stimulating, driving down slow frequency. And this is the first sample of a 7-year-old who was having some learning problems. There's the second sample, and there's the third sample. So it's an extraordinarily efficient way to help a child learn how to read properly, retain information, write, mathematics, and so forth. These data were collected by Mari Swingle, by the way. Okay, any folks have some questions, Rita?
Yes, thank you, Dr. Swingle. First question, can poor nutrition also be a factor in inattention? We have so many children coming to school without breakfast and bringing chips and pop for lunch.
Absolutely. Diet is a huge problem. And one of the problems we have is if they do eat, they're eating carbs and sugars. So that it doesn't take very long before they have a sugar crisis. The proper breakfast for a child is extraordinarily important, and diet generally, of course, is extraordinarily important. Whenever we're working with our children populations, we're always working with parents in terms of proper nutrition. Sleep is a biggie. Parenting, setting up the environment to really be, to facilitate the child's learning and so forth. But you're absolutely right. Diet is a huge issue.
What are some of the contributing factors for children to have abnormalities in brainwave function at birth? Would it be primarily brain trauma?
There are a lot of issues. The first is genetics. We see that ADD issues run in families, as does depression, for example. Birth trauma can be a big issue. And there are a number of conditions associated with the nutritional and emotional state of the mother during gestation. So all of these are critical elements, and often when you're looking at something like trauma, this is what I mean by, are you sure it's ADD? You know, it may not be ADD. It may have something to do with an emotional impact on the child. Good news about doing neurotherapy is you look at the brainwave activity and you know precisely what it is that you're dealing with, whether you're dealing with ADD or whether you're dealing with trauma and so forth.
Are these conditions the real ADHD conditions, the ones that are treated with medications?
Generally speaking, that's true. The problem is there are some ADD things that don't, ADD conditions, that is what we're calling legitimate ADD, that don't respond to medication. For example, the medication, central nervous system stimulants works for conditions in which you have elevated theta activity up over the sensory motor cortex. When the brain is hypoactive, in other words, that's the condition that responds to central nervous system stimulant. If you use a central nervous stimulant for somebody who has high frontal alpha, for example, you may not get a beneficial effect. In fact, you may get an issue associated with heightened anxiety, sleep disturbance, and so forth. Our preference, of course, is to minimize the use of medications in these kinds of conditions. We may use medication to help a child during the transitional period, but The answer to your question is yes, there are several of the conditions that I just referred to that do respond to medication.
Okay, we'll take one more question and then we'll have a second break later on. So if you would like to get your questions answered, send them in. How do you diagnose these conditions?
That's exactly what we were just referring to, in which you do an assessment, evaluate the brain activity, and determine whether the slow frequencies, for example, are above normal range in various areas of the brain. The one that I showed you, the actual data associated with the high frontal alpha, the way we knew that that was high frontal alpha ADD is the amplitude or strength of the alpha in the front part of the brain. That's the way these conditions are diagnosed.
Thank you, Dr. Swingle.
Is it truly ADHD? Okay. Remember this slide, I showed this at the very beginning of the webinar. The other conditions that are associated with inattention that do not respond well to things like methylphenidate. Issues such as head injury, depression, anxiety, bullying, family problems, of course, sleep, and physical problems. Now, this is very interesting, and these data were published in the journal, the Canadian Medical Association journal, last March. This is something that's been known for some time, but these are some interesting Canadian data. And children that are born in December versus those born in January, if you're dealing with a child who's, say, 6 years old, you're dealing with a huge difference in maturation between those two children. And so you can see here that boys born in December, and 30 versus 70% more likely to be diagnosed with ADD than if they're born in January. Okay, that's huge. And of those, 5.5% of the boys and 1.6% of the girls receive treatment for ADD. Now, the problem isn't ADHD. The problem is the child 1 year younger than everybody else in the class. And, of course, there's a maturation issue. So here's one of the cardinal examples of a problem associated with the diagnosis of ADHD, when, in fact, the problem is maturation, not ADHD. This is a topographic map of a condition associated with both depression and anxiety. Now, if you look at the top row and the one up on the top left, this is the distribution of theta in the brain. Theta, again, are brain waves from 3 to 7 cycles a second. You can see there's marked elevation of theta up over the left side of the brain, the left frontal part of the brain. Now, that's a marker for predisposition to depression. When the rule for determining or diagnosing depression is when the right side of the front part of the brain is considerably more active than the left. In a lot of ways that can happen, but one of the ways is to have elevated slow frequency in the left, and slow frequency again means hypoactive. So this is a topographical representation of a person whose left side of the front part of the brain is less active than the right, and that's a marker for depression. Depression in children very often doesn't reflect itself initially as sadness, but is often reflected in terms of just lack of interest and energy. Now, the second marker here of some importance is again, looking at the top row, the one on the extreme right, and you can see here there's a marked elevation of fast frequency in the back of the brain, occipital region in the brain. That's a marker for predisposition to anxiety, poor stress tolerance. But in particular, this is a condition that's very often diagnosed as ADHD, hyperactive. And the problem here is poor stress tolerance and a lot of chatter going on in the brain. This is a situation which the person simply can't find the switch to turn the brain off. There's a lot of chatter, and that's interfering with the child's ability to concentrate. This is a good example of a condition that would be made markedly worse with a central nervous system stimulant. Okay? And emotional problems in children. Okay. Emotional and behavioral problems in children causes family difficulties. The families are more likely to experience financial problems related to the child's health. One or both of the parents are likely to experience reduced or stopped work because of the child's health. Spend 11 or more hours per week providing or coordinating care for this child. And oddly enough, children that come in with emotional behavioral problems referred by the school seem to be less likely to have a personal physician. There's a lot of comorbidity associated with emotional behavioral problems in kids. And the ones I want to point out here is 50% learning disorder and 50% ADHD. So we have a huge number of these kids that have an emotional issue that are diagnosed with an attention or learning problem. Okay. Now, the problem here is if they're diagnosed with an ADHD and put it on something like methylphenidate, they're very likely to exacerbate the emotional behavioral problem. Bipolar pediatric bipolar disorder, it commonly starts in childhood and adolescence. Not well managed. On average, they're on 3.5 medications and an average of 6 trials of psychotropic medication to try to get it under control. Highly comorbid. There's just a lot of things that go along with it. Over 90% receive some form of psychotropic medication. Diagnosed with ADHD in children, a third of them are diagnosed with ADD, when in fact it appears to be a pediatric bipolar condition. Parental depression, this is huge. We find that a lot of children who come in with learning and emotional, behavioral, and attention problems, when we check out the parents, one or both are clinically depressed. That's a huge problem for a child because a depressed parent is not emotionally available to the child. That's what the problem is. And in males in particular, the depression deprives them of motivation, so they're much less likely to go out and play ball with their boy if they're depressed, and more likely to be sitting on the sofa bemoaning the fact that life is not good. So these are the data associated with this. Children that arrive with emotional behavior problems, 20% the mother is depressed, 10% the father is depressed, 20% both of them are depressed. Okay? So that's a huge number of these kids coming in with these kinds of conditions who are themselves diagnosed with emotional behavioral problems. So who are we treating here? Treating the kid, treating the parent? Anytime we see a marker for a trauma on a child, we always want to keep in mind that we have an awful lot of abuse going on in our culture. These are U.S. stats, but Canada isn't far behind. 25% of females under the age of 18 have had sexual encounters without consent. 16% of males. Talking about depression, we always think of postpartum depression as a female issue, that is, the mother gets depressed, but you can see that 10% of the fathers have depression that's coincident with the birth of a child. Okay. This is a 13-year-old boy. He was brought in for an attention problem, attention deficit disorder, okay? He just doesn't sustain attention, no interest in things. He's not hyperactive, so he was diagnosed as ADD, inattentive variety. And what is screaming at us here is, if you look at the column for F4, that's the right frontal side of the brain, and beta is 58.6% stronger in the right relative to the left, and that is your cardinal marker for depression. A genetic predisposition to depressed mood states. This child is depressed, and one of the symptoms associated with depression is the child is deprived of energy and motivation. Okay, methylphenidate doesn't touch this problem. Okay, so what we do is we treat the depression, and the child becomes more interested in things, and the teacher is happy, and everybody's happy. Okay, it has nothing at all to do with ADD. Here's where we tend to see the culprits associated with conditions that are not really ADD, where the right side of the brain is more active than the left, where there's an anxiety condition because of deficiency of enough slow frequency in the back so that the brain can quiet itself, and elevation in an area right under this region in the brain referred to as the anterior cingulate gyrus. And when that's hot, the child tends to perseverate. There's a lot of worry. It's obsessive compulsive kind of behaviors.
Okay, we have a few more questions here. Dr. Swingle, is there research to show that the Omni-CD is effective for CADD? Where can it be found? Could the Omni make the inattention during activity worse for some children?
There's a lot of data on the effectiveness of Omni. The first article was published in the Journal of Neurotherapy. One of the first editions of the Journal of Neurotherapy has an article on the treatment of common ADD with the harmonic. That's one of the harmonics in the Omni harmonic. We always test the Omni harmonic before we prescribe it so that we know what it's doing to the slow frequencies in the brain. Excuse me. And for roughly 90% of the children that show this condition, Omni will actually suppress the amplitude of theta to a significant extent. There's a percentage in which it appears to exacerbate the problem. And Omni for an anxious child is not a good idea because Omni does have a stimulating effect. So if the child has elevated beta activity in the back of the brain, that is the anxiety profile, then Omni is not a good choice. There are other harmonics, serene, for example, that will help quiet the back of the brain. And serene, one of our harmonics, would not be a good idea for a child that has inattentive ADD, legitimate ADD.
Does learning martial arts help children with ADHD to self-regulate?
You bet. I'm a big believer in that. But a lot of it has to do with who's doing the training. the martial arts master is the critical element here. When you have a martial arts instructor who is experienced with working with children, it can have very, very positive, dramatic effects on that child. The child learns discipline. The child's learning a lot of things associated with self-regulation. Yeah, we strongly support that.
My daughter was diagnosed with ADHD and given several medications that either did not seem effective or made her irritable and couldn't sleep well. Did she not have ADHD?
Probably not. My guess is that she had a problem associated with the back of the brain, and that is poor stress tolerance, which interfered with her ability to sustain attention and be able to retain information. And the medication probably exacerbated that condition and affected her sleep. They probably also monkeyed around with off-label use of antidepressants and antipsychotics, which they tend to do, and that can really mess things up. But my guess is you're right, that she probably did not have an ADD condition. She had one of these other conditions that we're discussing today.
My 8-year-old's teacher says he's very disruptive in class and aggressive to other children. I don't see this at home, but he's very active, maybe even hyperactive, but never aggressive. What would you suggest?
I would suggest stop calling it aggression. And I think what it is these kids just get really, really hyper in the class situation and overly exuberant. And pushing and shoving is part of the play activity. So my guess is you're not dealing with that, with what we would define as aggression. But the proof is, go in and watch. You know, you're the mother, you outrank everybody, so you can go in and observe your child in that condition and see whether it has the character of aggressiveness, and then you take corrective action in terms of your parenting. But a lot of this has to do with misdefining a behavior that's simply exuberance as opposed to being aggressive in nature. And the way we talk to a child about this is important because you're defining their behavior for them.
Thank you, Dr. Swingle. We'll have to move on.
Okay, this is the biggie, bullying. One of the nice things about the clinical cue, which is the brain assessment that we use at the Swingle Clinic, and a lot of other clinics around the world are using it, is that you're able to identify some really interesting situations in terms of how the situations like bullying or bad relationships and so forth are affecting brain activity. And I was suspicious of bullying here for the following reasons. And I'm showing you raw data here so that you get an idea of just how accurate this can be. CZ is an area right on top of the head. And when you ask an individual to open and close and then open his or her eyes, what you should get is a nice jump in alpha, the brainwave from 8 to 12 cycles a second when the eyes are closed because you're blocking the visual field. And we expect that jump in alpha at this location to be at least 30%. And you can see we're sitting at about 19% here. So one of the flags goes up. Okay, what's causing that? And the second thing that we have a look at is the back of the brain. And what we're seeing here is a bit of a deficiency in slow frequency for a child this age. 9-year-old child should be swimming in theta. And the theta-beta ratio in the back of the brain should be up around 2. It's okay as eyes open, but eyes closed is a little on the low side. So I'm suspicious that this child, A, is having some sort of traumatic experience, and B, is not sleeping adequately, so not dealing with the emotionality in the sleep, and is probably fatigued and cranky. So then we have a look at the front part of the brain. And here we're picking up a huge marker for what's called reactive depression. And that's where the right side of the brain is more active than the left. And the reason it is because alpha is considerably stronger in the left relative to the right. Now, the reason I refer to this as reactive is that you can cause this in the laboratory. If you make somebody unhappy, what often happens is you increase the alpha on the left side of the brain. So we're inclined to think of this as more a reactive depression that is associated with something going on in the real world as opposed to a genetic predisposition. The other item associated with this is this child has a genetic marker for emotional volatility. So my guess is that this child is very easy to provoke and will cry very easily, becomes emotional very easily. And he's a magnet for bullies. Okay? They don't have to do much to get a huge reaction out of this poor kid. Now, the trauma, he's frightened and he's depressed. And he has this emotional volatility. Here's an extremely good example of how using conventional top-down procedures associated with identifying symptoms to call this ADD would be grossly inaccurate, and we would be treating exactly the wrong condition in this child. Methylphenidate, antidepressants, antipsychotics, all that off-label use of stuff in this child would be a disaster. So it turns out we were 100% on the money here, and the child was being seriously bullied, was reacting with high levels of emotionality, crying and so forth. So taking some corrective action in the school, we did a bit of neurotherapy with him to correct this hyper reactivity issue. Talk to the child about doing optimal performance training, put it in the context of we're doing the same training with him that we do with hockey players and Olympic gold medal winners and so forth, but got the bullying under control, and that made all the difference with this young child. Here's the high frontal alpha. Now, I showed you this once in the earlier slide. Here we do have an ADD issue, high frontal alpha, okay? But we have a comorbid condition of a genetic predisposition to depressed mood states and emotionally volatile, okay? Now, this is a situation in which methylphenidate is not going to be very effective. An antidepressant might have some benefit, but much better idea is to simply correct this by balancing the front part of the brain, getting the right and the left to be pretty close in the amplitude, and driving down that elevated alpha activity. Here again, situation in which this is an anxiety marker in the front part of the brain. And this child was diagnosed with ADHD, ADD with hyperactivity, the hyperactive variety. And what this child has is he has a marked disparity in the front part of the brain with beta amplitude being considerably greater in the left relative to the right. And that's the marker for predisposition to anxiety states and hyperemotional. Oppositional defiance. I love treating these young guys. They're just so full of vinegar. In any event, this is the marker for ODD, in which the right side of the brain has marked elevation of alpha. which is what he's showing here. He's also showing a depression marker and a hyper emotional volatility marker, which we often find with oppositional defiance. The kids tend to be very bright, so they're really, really good at manipulation and finagling and so forth. They're a lot of fun to treat. Not a lot of fun to parent, by the way. Okay, child in crisis. And this is a 7-year-old. So the first thing we're picking up here is a trauma marker. Okay, so the first flag goes up. What's causing the trauma? Back of the brain, a second trauma marker. Very poor stress tolerance. Remember, in the back of the brain, we want the theta-beta ratio to be up around 2, sitting at about 1. So here we have a condition, poor stress tolerance, predisposition to anxiety, sleep quality problems very likely, and 2 trauma markers. So something serious is going on with this young child. Front part of the brain. What we're seeing here is marked elevation of beta in the front. That's a hypervigilance marker here. Okay, so this child is afraid. This child can't let her guard down, so to speak. And delta is extremely high. And delta is about 2 cycles a second in the front part of the brain. And often this is a mechanism for dealing with fear in a young child. That is, they're shutting down the front part of the brain. And this is a marker for fretting and worrying. And this is the summation of all the fast brain waves from 16 to 40 cycles a second. We want it below 15. She's 3 times that value. So I know this child is worried sick. And she has hyperactivity of that region in the brain we were talking about in terms of obsession compulsion. So she has all of this stuff, and it's just cycling around, getting worse and worse and worse. And she's extremely bright. Okay, so here's a condition of extraordinarily critical child in crisis. And treating this child for ADD gives stupidity new meaning. This is a very, very troubled child who has something that is really terrifying her. Turned out to be just a hugely serious family issue. She wasn't being abused or anything, but both of her parents were at the risk of terminal illness, and she was just sick with worry. Families. Okay, child brought in for an attention problem. I'm only going to point out a couple of things here. There's your trauma marker. So we've got trauma marker in 2 places. That is an inadequate alpha response. Okay, flags up. What's going on? Second child, trauma markers in both cases. Okay, other things going on, but trauma markers. Okay. Again, brought in for attention issue. The mother, trauma markers. Okay. What's going on? Very, very nice, pleasant father who recognized that he was the problem, came in, recognized that we would be treating the wrong people if we were treating his children for his problem. And here it is here. Huge alpha in the front part of the brain, hugely dysregulated. This is the high frontal form of ADD, misdiagnosed as depression and anxiety, and put on all kinds of garbage here, Wellbutrin and Cipralex and Ativan. He still flies off the handle at minor problems. He's still anxious, depressed, and fatigued. And the reason he's depressed, anxious, and fatigued is because he has ADD, high frontal form of ADD, and a severe form of it. Now, he does have mild problem associated with a stress tolerance, but it's peanuts. And he does have a mild issue associated with reactive depression, but it is peanuts as well, relative to this huge elevation of alpha in the front, which is causing all the emotional dysregulation, problems with planning, organizing, sequencing, and he's turned into a major issue. And you can see how without adequate brain assessment of all 4 people in this family, these children could be going down a long road of being treated for the wrong problem and the wrong person being treated. This is the power of neurotherapy in terms of assessment of what's going on, bottom up, not top down. Sleep quality problems. Here's what it looks like if you're doing an evaluation. Here's the eyes open data in the back of the brain. And then when they close their eyes, the back of the brain lights up. It should be going the other way. Now what happens is you close your eyes and the brain takes that as the signal to start worrying and fretting and thinking about all kinds of things. So here is what a sleep quality marker looks like when you're doing an assessment. Eyes open, eyes closed, beta should be dropping. Here it's markedly enhanced. Sleep, we're going to be doing a major webinar on sleep coming up, but just to give you an idea, the deep sleep and REM sleep are the 2 important areas in sleep. You need about 1 hour of deep wave sleep for the body to heal and restore itself, and you need about 2 hours of REM sleep for the mind to heal itself. That's when you're doing your own psychotherapy in your sleep, and it's also the brain's filing time, where it takes all of the stuff you learned during the day and puts it in the proper files in the proper filing cabinets. Without that, you don't remember what you've learned the day before. We do sleep monitoring here, we do 4-day assessments, and we get this kind of assessment. So here's a guy in trouble. Only 19 minutes of REM. Okay, just that tiny little bit. He needs 2 hours of REM in order to be able to retain information and in order to be able to deal with the psychological things going on during the day. Okay, very, very, very likely to be defined as ADD because the child can't retain information and the child's tired in school because their sleep stinks. Give them methylphenidate, you really make the problem worse. And the final culprit, internet addiction. Okay. This is obvious to any parent. Walk into your child and take their Game Boy or whatever you call them and just take it away from them and see what happens. Okay? You just watch that reaction. You know instantly whether you're dealing with an addicted child. The internet is highly, highly, highly addictive, particularly for children that have inattentive forms of ADD. And so it's something that needs to be regulated. We're going to be doing another webinar on this topic specifically because it has such serious implications, not only for young kids and students, but also for adults. And these are the areas of the brain that we've just been looking at that told us everything we needed to know. And that's part of the clinical assessment. And it gives you something that looks like this, 99 numbers. The 99 numbers boil down to 22. And from that, I know this child has a form of ADD. He has the pernicious form of ADD. It gets worse the harder he tries. And I also know that this child has been sneaking a little cannabis, which I told him, and he was very surprised I was able to see that. This is the write-up of Susan Olding, who wrote on the clinical assessment procedure we used. And here she said, one by one, he read the ratios, dividing my daughter more quickly, more accurately than any professional I'd encountered. That's the power of the clinical cue that allows us to be able to do that. And you can see up here, we don't look at any medical or developmental histories. When a child comes in, we simply read the clinical cue, and it tells us absolutely everything we need to know.
Okay, a little bit of promo time. Biofeedback for the Brain is the book I mentioned at the beginning, written by Dr. Paul Swingle and published by Rutgers University Press. It is really a great book for those who are interested in learning about neurotherapy. Questions like, my 8-year-old teacher says she needs Ritalin. I don't agree. What should I do? Or, my brother is a drug addict and tells me that his addiction was caused by his ADHD. Is this true? Are all answered in the book. You can get the book at www.soundhealthproducts.com. Basic Neurotherapy, the Clinician's Guide is a book for therapists. It leads clinicians through the procedures for evaluating and treating patients with a wide range of disorders. It is also available at soundhealthproducts.com. Swingle Clinic offers professional education and training, and these offerings include online grant round sessions, courses, and webinars managed by Biofeedback Foundation of Europe. The professionals who complete these courses are eligible to receive APA continuing education units. More information can be seen at Biofeedback Foundation of Europe's website at www.bfv.org. We also provide workshops here at Swingle Clinic. We have 2 3-day basic neurotherapy workshops scheduled for this year, one in April and one in June, and 1 3-day advanced neurotherapy workshop in October. These are limited to licensed healthcare professionals. For more information, you can email me at rita@swingleclinic.com. And another workshop we have scheduled for this year is for all mental health practitioners interested in working with transgender population and in developing confidence and competency to assist someone during and after a gender transition. The workshop will be presented by Lucas Walter, founding director of British Columbia FTM Network and past president of Trans Alliance Society. It is scheduled for Saturday, February 23rd here at Swingle Clinic. For our general public, Dr. Swingle is having a public lecture on Wednesday, January 30th from 7 o'clock in the evening. It is at the main library on Georgia Street, so if you know anyone who has any conditions associated with inefficiencies in brain functioning, they are certainly welcome to attend. The admission is free. For more information, again, you can contact me at rita@swingleclinic.com. And that is it, folks. We hope you enjoyed the time with us, and we'll be looking forward to having you on February 9th when Dr. Swingle will discuss seizure disorders. Have a fantastic weekend, everyone, and bye-bye. Thank you, Dr. Swingle.